Welcome once more to this channel. Kindly subscribe to this channel. The topic for today is applied anatomy of the back. This is part 2. Check out the other video on applied anatomy of the back, part 1. Now I need to start with back pain. Back pain is really a health challenge. Low back pain in particular is one health problem that you find commonly, second only to the common cold, and that is the reason why so many people visit their doctors. There are 5 categories of anatomical structures that receive innervation in the back, and these structures can be the sources of pain. 1, you have fibroskeletal structures. The fibroskeletal structures are periosteum, ligaments, and the anuli fibrosi of intervertebral disc. The second structures are meninges, that's the coverings of the spinal cord. 3 is synovial joints, the capsules of the zygapophysial joints. 4, muscles, the intrinsic muscles of the back. 5, nerve tissue. You have spinal nerves or nerve roots exiting the intervertebral foramina. So all these structures receive innervation in the back and can be sources of pain. The first 2, that's the fibroskeletal structures, the periosteum ligament and the anuli fibrosi of intervertebral disc, as well as the meninges, are innervated by the recurrent meningeal branches of the spinal nerves. Then the next 2, that's the synovial joints, the capsules of the zygapophysial joints, as well as the muscles, the intrinsic muscles of the back, are innervated by posterior rami, that's articular and muscular branches. You have pain resulting from nervous tissue. That is, such pain is caused by compression or irritation of spinal nerves or nerve roots. And the pain is referred to an area we call the dermatome, an area supplied by that nerve. But you can also have localized pain as well. Pain related to the meninges is relatively rare and is generally not considered to be an important factor as far as back pain is concerned. Localized back pain, that's pain coming from the back, is generally muscular. It can be muscular in origin. It could be joints, could be coming from the joints, could also come from fibroskeletal tissues. Muscular pain is usually related to reflexive cramping, that's spasms that come from ischemia. Often the ischemia comes as a result of guarding, that's contraction of the muscles. When the muscles are just expecting some kind of irritation and pain, they begin to contract and you have guarding, and this results in cramping and you have muscular pain. You could also have pain associated with the zygapophysial joints, and this comes very commonly with aging. You have some conditions like osteoarthritis or some other diseases like rheumatoid arthritis which affect the joints. So of course the intervertebral foramina are affected, and that's where you have the spinal nerves going through. So these spinal nerves are irritated and you have pain. Pain also comes from vertebral fractures and dislocations, and these pains are not different from the pains you have coming from the bones and joints when you have diseases like osteoarthritis. When you have a fracture, the patient will experience a sharp pain, and this sharp pain is periosteal in origin, and the pain a patient that has a dislocation experiences is ligamentous in origin. So when there's an injury to the ligaments or a stretch, you could have pain coming from there. There is acute localized pain associated with an intervertebral disc herniation, and this emanates from the posterolateral disruption of annulus fibrosus, and when this occurs, you have impingement on the posterior longitudinal ligaments, and you could have pain because the nerves are irritated nearby, and then pain comes. So pain in all these instances are conveyed by the meningeal branches of the spinal nerves. Now I need to talk about compression of the lumbar spinal nerves. You find out that the lumbar spinal nerves increase in size as you go from the superior part to the inferior part. It's unfortunate that the intervertebral foramina decrease in diameter as you go from the superior to the inferior aspect. So what is the consequence? The lumbar, you find out that the L5, that's the fifth lumbar vertebra, it has a spinal nerve associated with it. Spinal nerve roots there are the thickest, yet their foramina are the narrowest. So there is an increased chance of these nerves being compressed if herniation of the nucleus pulposus occurs. So you have, when these lower spinal nerves, for example, are irritated, you could have caudal equina syndrome. Caudal equina syndrome is illustrated right here. Let me go on and talk about lumbar spinal puncture. Lumbar spinal puncture is also called spinal tap. You do it because you want to extract or sample CSF from the lumbar system. And it's very important as far as diagnosis is concerned, diagnosis of a variety of central nervous system disorders. Right here you have an illustration of how lumbar puncture is done. You can see the patient lying there by the side, on the side, and the procedure is illustrated there, and the anatomy that is involved, concerned, is illustrated there. I'm going to talk about that shortly. So in lumbar puncture, for example, when you have patients with meningitis and diseases of the central nervous system, what happens? Such patients have altered cells, the cerebrospinal fluid. At times you could also have a change of concentration of chemical constituents in the cerebrospinal fluid. So you might need to examine the cerebrospinal fluid to determine the cells and then the chemical constituents. Also, you want to see if blood is present. So it's really important in diagnosis of central nervous system disorders. Lumbar spinal puncture is performed with the patient lying forward or lying on the side with the back flexed. Why do you have to flex the vertebral column? You have to flex because it facilitates insertion of the needle by spreading the vertebral laminae and also spreading the spinous processes apart. And also you have stretching of the ligamental flavor. So all this gives you some space for your lumbar puncture needle to go in. You have to do it under aseptic conditions, that you get a solution like you get swab, cotton wool soaked in spirit you use to clean the skin covering the lower lumbar vertebrae. And you, after cleaning the skin, you need to also spray with anesthesia. You anesthetize. Thereafter, a lumbar puncture needle is inserted. This lumbar puncture needle is fitted with a stylet. So it's inserted into the midline between the spinous processes of L3 and L4, that's the third and fourth lumbar vertebrae. You can also go as low as between L4 and L5, that's between the fourth and fifth lumbar vertebrae in a child, because the spinal cord is, due to the location of the spinal cord, it's more inferior in the child. You don't want to pierce the spinal cord and injure the spinal nerves. Don't forget that there is a plane that transects the highest point of the iliac crest. That plane is the supracrestal plane. So it usually passes through the L4 spinous process. So when you palpate the iliac crest by the right and left, the plane that joins both of them, the supracrestal plane, at the midline, just at the midline, that plane, at the midline of it, you have this L4 spinous process. So at that level, you can insert your lumbar puncture needle, and there is no danger of damaging the spinal cord. You insert the lumbar puncture needle, and the lumbar puncture needle is going to go through the skin, the subcutaneous tissue, supraspinous ligaments, interspinous ligaments, the ligamentum flavum. Then it will get to the epidural space. It will go through the dural. After going through the dura, is going to go to get to the arachnoid, go through, and then it finally to get to the subarachnoid space. At that point, you're going to feel a give, like as if the needle is free, since it has been passing through some form of structures. At the point it gets into the subarachnoid space, you feel some give, like when we say give, it means the needle is as if it's free. You have some kind of, it's in a free space. So it will get to that point after passing 4 to 6 cm in adults. But this distance may be a little bit longer in obese persons, that's people that are overweight with so much fat. The needle punctures the dura mater, and like I said, and the arachnoid mater, and it gets to the subarachnoid space and enters the lumbar system. Then you now remove the stylus. You remove it, and then CSF begins to escape at the rate of about 1 drop per second. If you find out that in some cases some patients have high subarachnoid pressure, and what happens, the CSF will flow out, or it will escape as a jet. The pressure is going to be increased, going to rush. Instead of dropping at 1 drop per second, it will rush. So when you see the CSF rushing like that, you know that the pressure is high. There's high subarachnoid pressure. Lumbar puncture is not performed in the presence of increased intracranial pressure. So usually before you do it, you might want to check to determine what the intracranial pressure is like. You can do that via CT scanning, but there are times that you might not have that facility. So what do? You can also examine the fundus, that's the back of the interior of the eyeball. You can do that with an ophthalmoscope, so you will be able to tell if the intracranial pressure is high. If it is, you don't bother to do lumbar puncture until the patient is treated and the intracranial pressure comes down. So much so for lumbar puncture. Next, I'm going to talk about spinal block. In spinal block, you're going to insert your needle. You want to give anesthesia. For example, in childbirth, a woman wants to do surgery, cesarean section. She does not want to go through general anesthesia, so she wants to be either awake or you can still sedate. So you might want to do a regional anesthesia. So spinal block is one of them. An anesthetic agent is injected into the cerebrospinal fluid in the subarachnoid space. So you use a needle. There is a needle that is meant for injecting spinal anesthesia, anesthetic solution. Such needle is going to be inserted right into the subarachnoid space. You're going to go just the way you went when you were doing lumbar puncture. So your needle is still going to be inserted through the same anatomical structures. It's going to go the same way, but it's a different needle now, because this needle is meant for what? Injecting spinal anesthetic solution. So it's a different needle, but it's going to be inserted just the same way the lumbar puncture needle was inserted, so that you can inject an anesthetic solution agent into the cerebrospinal fluid. When you do that, what happens? Anesthesia occurs within a minute. At times you might have a headache going with a spinal block. This is as a result of leakage of cerebrospinal fluid through the lumbar puncture. So as your needle is going in, you are injecting this anesthetic agent. Some cerebrospinal fluid might leak in the process. So because of that, you might have what? Some form of headache. Right here is an illustration of the spinal block. So you see how the needle goes in. You can see the needle going in, inserted right there into the subarachnoid space. So you inject the anesthetic agent into the cerebrospinal fluid. Okay, let me talk about epidural block. In epidural block, you also doing regional anesthesia. An anesthetic agent is injected into the extradural, that's the epidural space. So in this case, you are not going to go into the subarachnoid space. You're stopping at the what? Epidural space. And you use the same position that we described for lumbar puncture, spinal puncture. You could either use that position if you're doing a lumbar epidural block. So if you want to do an epidural block, the question is it a lumbar epidural block you want to do? If it's a lumbar epidural block you are doing, you're going to go insert your needle just the way you did when you were doing a lumbar spinal puncture. But of course, it's a different needle. The needle with containing the anesthetic agent solution that you want to use for the epidural block. But you insert it just the way you inserted the needle for the lumbar puncture. So that you call that lumbar epidural block. So your needle will be inserted with the patient will flex the vertebral column. It could either sit and flex or lie on the side and flex. You insert your needle, you go through the skin, the subcutaneous tissue, supraspinous ligament, interspinous ligament, to go through the ligamentum flavum. Then you have to get to the epidural space, go through the dural matter to now get to the arachnoid, and then at the subarachnoid space, you're going to inject your anesthetic agent. That's for lumbar epidural block. What if you want to do a caudal epidural block? In that case, you're going to go through the sacral hiatus. So for the caudal epidural block, you're going to go through the sacral hiatus. So in this case, how do you go? You're going to try to locate the sacral hiatus. You try to locate it, you get to the buttocks. You need to look at the buttocks, the cleft between the buttocks of the individual. You find the sacral hiatus lying about 4 cm above the tip of the coccyx, beneath the skin of the natal cleft. You can palpate it as a distinct depression in the midline about 4 cm above the tip of the coccyx, that's in the upper part of the cleft between the buttocks. So the cleft between the buttocks get to the upper part. You will find the sacral hiatus about 4 cm above the tip of the coccyx. You can also palpate the tip of the coccyx there. About 4 cm above it is the sacral hiatus. You're going to inject your needle, and needle will go in, get to the epidural space, and you're going to inject the anesthetic agent. Right here is an illustration of the epidural block. So you see how the needle is inserted from that diagram and the anatomical structures that it goes through. Now let me discuss the ischemia of the spinal cord. You have blood supply of the spinal cord from segmental medullary arteries, which get blood to the anterior and posterior spinal arteries. So in cases where you have fractures, dislocations of the vertebrae, at times you have combinations of fractures and dislocations occurring, the bones might be displaced, and then displaced bones will going to interfere with the blood supply to the spinal cord. So they interfere with the spinal and medullary arteries. So what happens when the blood supply is disturbed? You have deficiency of blood supply. That is what we call ischemia of the spinal cord. And of course, this is going to affect its function, and it can lead to muscle weakness and paralysis, because the spinal nerves are once they are not getting their blood supply, they are not nourished, the spinal nerves cannot function, and then what happens? The muscles that are supplied are going to lose their motor function, so you have muscle weakness and paralysis. The spinal cord might also suffer what we call circulatory impairment if you have segmental medullary arteries. One very important one we call the great anterior segmental medullary artery of Adam Kewis. Narrowed, it could be narrowed by obstructive artery disease. So it could be narrowed when you have atherosclerosis, for example. You could narrow this artery, and then it will interfere with the circulation, blood circulation to the spinal cord as well. So not only the injuries, that's the fractures and dislocation, you could also have diseases like obstructive artery disease, impairing blood supply to the spinal cord. Yes, I must talk about spinal cord injuries. Very important. Spinal cord injuries. Nobody wants to be affected by that. You have protrusion of a cervical intervertebral disc into the vertebral canal after a neck injury. So someone has a neck injury, for example, it could affect the intervertebral disc, it could be displaced, and you have protrusion of the cervical intervertebral disc into the vertebral canal around that region. And this may cause spinal cord shock. This is associated with paralysis inferior to the site of the lesion. So inferior to the site of the lesion, you have paralysis. There could be encroachment of the vertebral canal by a protruding intervertebral disc. Also, the vertebral canal could also suffer some form of encroachment by swollen ligamental flavor. And you could also have encroachment resulting from osteoarthritis of the zygapophysial joints. This exerts pressure on one or more of the spinal nerve roots of the chordae equina at the lower part of the vertebral canal. So you have pressure. The pressure results in sensory and motor symptoms in the area of distribution of the involved, that's the affected spinal nerve. There is a group of bone and joint abnormalities called lumbar spondylolysis, that you have a degenerative joint disease, and this makes part of the vertebra to wear off, and it degenerates, and you have it's as if the vertebral body is separated from the arc, and you could have localized pain and stiffness resulting, because once the intervertebral foramen is affected, the spinal nerves are irritated, you must have pain. So you could have localized pain and stiffness. There is stiffness because the muscles that are affected, that are supplied by that spinal nerve that is affected, the muscles will suffer. So you're going to have stiffness. Right here is an illustration of spinal cord injury. Really, really pathetic. So you have an illustration of spinal cord injury. You have the diagram at the extreme right, that your right, you have the color, some colored persons. You see the coloring, the blue color and the brown color at the top, gold color at the top. The area covered by these colors varies. So the blue color is actually referring to the area that is affected by spinal cord injury. So that's the area that suffers. While the gold color, the upper part, is actually the area that is spared. So the spinal cord injuries are the level between the blue and the gold color. That's where you have the spinal cord injury illustrated in that diagram. And then when you go to the left, you will see the vertebral column and the spinal cord. So the various levels at which it can be injured, they are all illustrated there. And what you see depends on the symptoms you see, depends on the level at which the injury, spinal cord injury, occurred. That is what that diagram is trying to explain there. I'm going to explain the details shortly. Transection of the spinal cord results in loss of all sensation and voluntary movement inferior to the lesion. So at that, when you look at the diagram, there's transection of the spinal cord at a level that's at the level between the blue and the gold color. And what happens? You have loss of sensation and voluntary movement inferior to the lesion. Transection of the spinal cord between the following levels will result in the indicated effects. At the C1 to C3 level, that's between the first cervical vertebra and the third cervical vertebra, what happens if there is transection anywhere between this around here? What happens? You will not have any function below the head level. So all functions, you can see that in the first diagram, the first person there that is closer to the left of the diagram, that seems to be at the top. So that person is actually in so much trouble, though he's appearing to be at the top. But don't envy him because he's in so much trouble. All the functions below the head level are lost. So such a person might die instantly, except he has a ventilator. So he needs a ventilator to maintain respiration because the phrenic nerves are already affected. And you know the phrenic nerves innervate the diaphragm, very important in what? Respiration. What about a lesion at C4 to C5 level, that's between the fourth and fifth cervical vertebrae? What happens? You see the second person as you are going down in the diagram there. He has such a lesion. Such a person can enjoy respiration. He can breathe. He will not die without a ventilator. But the patient is quadriplegic. That is, he cannot use both upper and lower limbs. He cannot use both the legs and the hands. Such a person is going to be on wheelchair. He might not even be able to move the wheelchair. He will just be there on the wheelchair. So he will need somebody to roll him or her around. So he's quite disabled. What about a lesion at C6 to C8 level? That's between the 6th to 8th cervical vertebrae. Between the 6th to 8th cervical vertebrae, what happens there? When you have a lesion there, the patient experiences a loss of hand and a variable amount of upper limb function. And the person may be able to self-feed or propel a wheelchair. So he or she may be able to feed himself or herself depending on the exact level where that lesion occurred. And he might be able to propel a wheelchair. So he has a variable level of limb movement. So it depends on the level. If it occurs at the C6 level, for example, C6 to C7 level, it's quite high. Such a person might not be able to self-feed or propel a wheelchair. But if it's at a lower level, C7 to C8 level, that individual might be able to self-feed or propel a wheelchair. Now, what happens if you have a lesion at T1 to T9 level? That's any level between the first thoracic vertebra and the ninth thoracic vertebra. That's where this one affects the cervical and lumbosacral enlargement. So such an individual has paraplegia. There is paralysis of both lower limbs. Then the amount of trunk control varies with the height of the lesion. If the lesion is at a lower level, as low as the T9 level, the individual might have a good amount of trunk control. But if the lesion occurs at a higher level, that's T1 to T2 level, for example, the individual might not have much trunk control, in addition to suffering from paraplegia. T1 to T9 level, spinal cord injury at that level, the individual must have what? Paraplegia, that's paralysis of both lower limbs. What about lesion at T10 to L1 level, that's between the 10th thoracic vertebra and the first lumbar vertebra? What happens to that patient? That patient is still going to suffer. If we have some thigh muscle function, he might be able to walk with long leg braces. So such an individual might, you see him limping with some kind of braces, long leg braces. Then you have a lesion at a much lower level, between the L2 to L3 level. The individual retains most leg muscle function, and he will suffer a bit. He might need to wear some short leg braces for him to walk around. So spinal cord injury is no joke at all. So much so for that, I must talk about back strains and sprains. Back strains and sprains. Back strains and sprains. Back sprain is an injury in which only ligamentous tissue or the attachment of ligaments to bone is involved, without dislocation or fracture. So in back sprain, there is no dislocation, there is no fracture. What you have is an injury to the ligaments. What causes back sprain? Excessive strong contractions that occurs related to movements of the vertebral column, such as you have with excessive extension or rotation, could result in back sprain. Now let's go on to talk about back strain. Back strain involves some degree of stretching or microscopic tearing of muscle fibers. Back strain is a common back problem you have in sportsmen and women. It results from very strong muscular contraction. So, like I said, it involves some degree of stretching or microscopic tearing of muscle fibers. So the muscles usually involved are the ones that produce movement of the lumbar intervertebral joints, especially the erector spinae muscles. So once the muscle is involved, is injured, it results in back strain. Next, I need to look at the surface anatomy of the back muscles. Don't forget that in the midline of the back, there is a posterior median furrow that overlies the tips of the spinous processes of the vertebrae. A good look at this diagram here will assist one to appreciate the surface anatomy of the back as far as the back muscles is concerned. The furrow is a continuous, the median furrow, the posterior median furrow you have on the back is continuous superiorly with a knockout groove in the neck. Don't forget that the posterior median furrow is deepest in the lower thoracic and upper lumbar regions. So you can palpate that on the back of your friend or sibling. The erector spinae muscle produce the erector spinae muscles you have on the right and left, produce prominent vertical bulges on each side of the median furrow. So when you look at the lumbar region, the erector spinae are readily palpable and their lateral borders are indicated by shallow grooves in the skin. So you can appreciate the lateral borders of the erector spinae in the lumbar region and by the shallow grooves you see in the skin. When standing, the lumbar spinous processes, you can appreciate them. The surface marking of these spinous processes is the depression in the skin. So when standing, when you see depression in the skin in the lumbar region, it's due to the lumbar spinous processes. These lumbar spinous processes usually become visible when the spinal cord is flexed. Remember, in lumbar puncture, we say the spinal cord has to be what? Flexed for the lumbar spinous processes to become visible. So it will be easy for you to locate between L3 to L4 or between L4 to L5 for you to insert a lumbar puncture needle. So the knowledge of the surface anatomy is very important as far as lumbar puncture is concerned. Now we're still looking at the surface anatomy of the back muscle. The posterior median furrow ends in a flattened triangular area covering the sacrum and is replaced inferiorly by the intergluteal cleft. We talked about earlier on, I talked about the anesthesia, caudal epidural anesthesia, and you need the knowledge of surface anatomy of the back here to carry out that procedure. When the upper limbs are elevated, the scapulae, they move laterally on the thoracic wall, and then the rhomboid and teres major muscles now become visible on the back. And you also have the superficially located trapezius and latissimus dorsi muscles connecting the upper limbs to the vertebral column. You can also see that visible on the back. So much so for the surface anatomy of the back muscles. Now I cannot end this without talking about medical imaging of the back. There are certain procedures that are very important as far as radiological examination of the back is concerned. Radiography is the first one I want to talk about. Radiographical examination of the vertebral column usually requires both anterior-posterior radiographs and lateral radiographs. So both anterior-posterior views of the X-ray of the back as well as the lateral views of the X-ray of the back is necessary. Right here you have back X-ray. This is anterior-posterior view. So with a radiography, you can appreciate if a patient has a fracture. If it's a dislocation, you can also tell. If it's a combination of fracture and dislocation, you can see that on the radiograph. That's the X-ray. Still considering medical imaging of the back, myelography must be mentioned. Myelography is a radio. In myelography, what do? You're going to introduce a radio-opaque contrast substance, and this allows visualization of the spinal cord and spinal nerve roots. So with X-ray, what you see is mainly the hard tissues like the vertebral bones, the vertebrae. You can appreciate them clearly on X-ray of the back. So when you carry out radiography of the back, it helps you to appreciate the bones that you have there, the vertebrae. So for you to tell if there's a fracture or dislocation. But when you really want to see the spinal cord, you want to see the spinal nerves, radiograph will not help you. So what do? You might do a myelograph. You might look at a myelograph. So you do myelography. You introduce a radio-opaque contrast substance, and then it will enable you to see the spinal cord and spinal nerve roots clearly. So how do you do this? You get into this, the cerebrospinal fluid is withdrawn by lumbar puncture. So you're going to go as if you're doing lumbar puncture. You withdraw cerebrospinal fluid, that's the CSF. You now replace it with a contrast material which is injected into the spinal subarachnoid space. So you're going to go as if you're doing lumbar puncture. You get cerebrospinal fluid and replace it with what? Contrast material, the contrast solution. And the contrast is going to go into it will flow around, and then it will help you to visualize the spinal cord clearly and the spinal nerves. Right here is an illustration of myelograms of the lumbar vertebrae. The first illustration you have by your left is a frontal view, while by your right you have a lateral view of the lumbar region of the vertebral column, just the way you see it when you carry out myelography. So you see a myelogram of the lumbar vertebral column there. With myelography, you can see the extent of the subarachnoid space and how it extends around the spinal nerve roots within the dural root sheaths that enclose the spinal nerves. But now what we really have, you have magnetic resonance imaging, that's MRI, which has almost replaced myelography, because with MRI you can also see the spinal nerves clearly. Next, I need to talk about computed tomography, that's CT. It's popularly called the CT. With computed tomography, you can see the white and gray matter of the brain and spinal cord clearly. So when you're interested, you want to see the white and gray matter of the spinal cord, you might need to do computed tomography. It helps you to see clearly. Also, when you have some fractures of the vertebral column, you might want to do computed tomography to see if there is compression of the spinal cord, if the spinal nerves are involved, are affected. Right here is an illustration of the transverse CT images. From you have slices at sections at the different disc levels. That John is the lumbar vertebrae. That's the region you have the CT examination done, and then you have the CT scans images right there at the different levels. You have the transverse images right there, so it helps you to appreciate clearly at what particular level you have a particular lesion, like compression of the spinal cord, could be due to a fracture or for whatever reason. CT images of the vertebral column are used to detect fractures, like I said, in some cases, and some other lesions of the spinal cord, and then also congenital anomalies of the spinal cord. Also, the CT will help you to diagnosis and management of such treatment of such patients. Because as you treat, you want to also see, you want to follow up. There is dense vertebral attenuation, and it makes it very clear. You now see the vertebrae appearing whitish on the scan, CT scan, just like you have in the diagram there. So you can see transverse sections of the lumbar vertebrae, which are colored with clear whitish there. They have white color there on the CT scans in the illustration you have there. Last but not the least, I want to talk about magnetic resonance imaging. Magnetic resonance imaging is a computer-assisted imaging modality, but this does not involve the use of X-rays as you find with CT. Magnetic resonance imaging gives very good images of the vertebral column, even of the spinal cord as well, and the cerebrospinal fluid is also seen clearly, and you have a clear demonstration of the components of the intervertebral disc Right there you see an illustration of a magnetic resonance image of the lumbar region of the spinal cord. It's actually a sagittal section there. So both CT and magnetic resonance imaging, they are sagittal imaging. So you take in sections. Right there you have a sagittal section of the lumbar region of the spinal cord. So you have, with magnetic resonance imaging, like I said, you have a clear demonstration of the components of the intervertebral disc. It also shows the relationship of this disc to the vertebral bodies and the longitudinal ligaments. So when you have herniations of the nucleus pulposus, you could appreciate it and you could see the relationship and how it relates to the spinal nerves and how the spinal nerves are in fact affected in such a situation. Magnetic resonance imaging is the imaging modality of choice for evaluating intervertebral disc disorders. So when you're suspecting there is a disorder of the intervertebral disc, you have to request for a magnetic resonance imaging modality. And it has replaced myelography and even computed tomography. It has replaced it as far as the study of intervertebral disc disorders are concerned. I really appreciate you for listening to me. Don't forget to subscribe to this channel. Goodbye for now.